Okay. Bismillah ar-Rahman ar-Rahim. It's a pleasure to meet today to present my second presentation. الصوت كده كويس؟ تمام. My second presentation today about bold MRI in renal allograft dysfunction, differentiating between acute rejection and ATN. Renal allograft dysfunction is a common and complex problem in which early characterization and appropriate management is critical to allow effective treatment and for long-term graft function and survival. Biopsy is considered the gold standard for diagnosis of graft dysfunction, but it is invasive and carries risk of complication. So non-invasive methods for further evaluation are desirable. Many trials using recent functional renal MRI are rapidly grown and could be used to evaluate the graft morphology and function non-invasively and their ability to diagnose different causes of dysfunction. Bold MRI is a non-invasive method can assess the regional tissue oxygen concentration on the basis of the paramagnetic properties of the deoxyhemoglobin as endogenous contrast agent. This is acquired by applying multiple gradient recall echo sequence from 8 to 20 echoes acquired during breath hold. As it determines the relative local tissue oxygen concentration, it can diagnose early transplant dysfunction as the blood oxygen level alterations occur during the pathophysiological course of the dysfunction. So, a decrease in oxygen concentration in a regional tissue results in increased deoxyhemoglobin concentration, which result in increased magnetic spin diffusing and decreased signal on T2 star image. The apparent transverse relaxation rate denoted as the R2 star, which is the inverse of T2 star, and it is proportional to the deoxyhemoglobin concentration. So, the increased R2 star value implies increased deoxyhemoglobin and decreased the oxygen bioavailability within this tissue. The renal medulla is in a physiological hypoxic state. There are contributors for physiological medullary hypoxia. The lower oxygen delivery results from the inhomogeneous renal blood flow and the arterial to venous oxygen shunting within the medulla. On the other hand, there is high metabolic demand in the medulla due to the sodium reabsorption process. So we had medullary limited oxygen supply and heavy demand, both result in poorly oxygenated medulla, which make it vulnerable to hypoxic injury. In normal functioning kidney, the oxygen concentration, we can we can see here the R2 star map, and we can see here the corticomedullary differentiation on oxygenation basis. Most of the studies revealed that the medullary R2 star values showed results that showed increased increased R2 star values in the medulla, and in acute rejection it showed decreased values. This is compared to the normal functioning grafts, and these changes and alterations in the R2 star values reduced after the recovery. In acute graft rejection, the increased oxygen delivery, decreased oxygen consumption, or combination of both result in the high oxygen medullary concentration, and so decreased deoxyhemoglobin and decreased the R2 star levels in the graft rejection. This is a recent study at 2023 at Mansoura. It showed also, it studies the bold in the renal graft dysfunction, and also showed the mean medullary R2 star significantly lower in the acute rejection compared to the ATN and normal grafts. And also to discriminate between the ATN and AR, the medullary R2 star was the best, gives the best sensitivity for discrimination. A lot of studies also from older to more recent studies showed also the same regarding the medullary R2 star. Our experience at Alexandria University, we had a study included 75 patients divided into 3 groups. Group A, 32 grafts with stable function, and Group B, 25 grafts with acute rejection, pathologically proven, and Group C, 18 graft recipient with pathologically proven ATN. This study conducted on 3 Tesla machine in coronal planes and press hold multiple fast field echoes. We used the 20 gradient echo, 8 press holds, 8 seconds for each, and ultrasound guided needle biopsy. Biopsy was done to determine the final histopathological diagnosis. Starting by the qualitative analysis of bold images, R2-star maps were generated and analyzed from the acquired bold sequence. We start by the color-coded R2-star map, where there is a scale here, where the red at the upper of the scale, this color indicates highest R2-star values, and at the bottom here, the blue color indicates the lowest R2-star values and the lowest deoxyhemoglobin values. For quantitative analysis, we applying GROIs in the cortical and medullary regions at upper and middle and lower zones at 3 mid-coronal planes. So we had 9 cortical and 9 medullary ROIs, and average them to get the final mean cortical R2-star and the final medullary R2-star values for each graft. Any susceptibility-related artifact excluded from the placed ROIs. Also, mean medullary cortical ratio, MCR, was calculated, and all these data was fed into a statistical analysis to give the comparison between the groups, and then we had ROC curve analysis and to detect the accuracy and sensitivity specificity for prediction of the acute tubular necrosis versus the AR. Starting by the qualitative analysis, we had cases, for example, for the normal graft that showed cortico-medullary color gradient, where the blue color seen in the cortex and the green and yellow and even orange color seen within the medulla. This denotes the high oxygenation level at the cortex compared to the medulla. This is the normal corticomedullary color gradient. However, in AR and ATN, this color gradient is lost. In AR, where the R2-star values are decreased, we will see a patch or areas of blue color denoting low levels of R2-star in the cortex and the medulla. And also in the ATN, this color gradient is lost, as we can see here, and we can see the yellow and green areas within the cortex and increased yellow and orange and red areas within the medulla. At quantitative analysis, the cortical R2-star values comparing the 3 groups, it revealed ATN was higher values. It is significantly higher with cutoff value more than 18.9 for prediction of ATN compared with the rejection group, with accuracy reaching 90.7. And there was no correlation or significant difference between the normal and rejection groups. The medullary R2-star values comparing the 3 groups also revealed ATN have the higher values compared to the other groups, and compared to the acute rejection, it had a cutoff value more than 26.3 for prediction of ATN, with also accuracy reaching 90.7. And renal acute rejection cases showed diminished significant lower values في الميدولا compared to the normal grafts. Also, the MCR, comparing the three groups, we found significant statistical difference in the normal groups. It had higher values than the ATN and ER groups, and there was no significant difference between the AR and ATN. These are examples for cases. This is example for a normal case. This is a T2 image for these cases, and we can also here again see the normal graft with cortico-medullary color gradient, and again in ATN it is lost with cortex seen yellow and green areas, and here the AR case with areas of blue color denoting the lower R2 star values. These are the R2 star map with the measured mean values. For the normal case 26.4, and for ATN cases it seems very high, 31.3, and for this case, rejection case, it is very low, it is 15.7 per second. Bold MRI can assess changes in renal oxygenation by measuring the R2 star levels within the cortex and medulla. The diagnostic value of R2 star parameter was good in predicting the allograft dysfunction from normal grafts, and the cortical and medullary R2 star values can discriminate between the ATN and AR with high diagnostic accuracy. A calculated MCR can predict the allograft dysfunction for other groups, but it can't differentiate between ATN and ATR in our study. Still, larger validating study will be necessary before functional MRI techniques can realistically match or surpass diagnostic accuracy of the current standard modality, but it is still promising non-invasive tool for evaluation of renal graft with the potential ability to differentiate between acute rejection and acute tubular necrosis. Thank you.
Thank you. Thank you.